I will speak about ocular surface disease. The alteration of ocular surface disease is definitely the pathology of the century. It may be associated with systemic disease. Frequently, it's more severe. Rarely, ocular surface disease related to the disease. It can help for the diagnosis of, for the rheumatologist or for the internist. Sometimes we receive patients with complications. So adequate care is mandatory to improving quality of life of this patient. First case is a patient, 28 years, consult for cataract surgery, no prior medical history. Ocular exam is normal with cataract. She has moderate dry eye. She is very young, but her family has early cataracts and operate three members of her family. I make a cataract surgery without any problem, multifocal IOL. The first day, clear cornea, good centration of the IOL. At the third day, the patient was very happy, but at the 12th day, she consulted in emergency because decrease of visual acuity since 3 days with moderate pain. And when we look at it, it's aseptic central keratolysis. She answered that, yes, I have joint pain for the past 2 years, especially in the morning and on my hands. No, I didn't consult. I thought it was normal with menopause. My ones get dry from time to time. So I addressed her to the rheumatologist, and the assessment showed that it is a rheumatoid arthritis related by aseptic central keratolysis. Aseptic central keratolysis is cornea stromal disease without or with moderate pain. It's a central clear perforation without infiltrate, without neovascularization, and with a fast evolution. And it can see with cataract surgery, with non-steroid anti-inflammatory drops, and Sjogren syndrome in rheumatoid arthritis, in herpes, and in chemotherapy. The second case is a patient, 36 years old. She consulted for red and painful pain, ACE with filamentous secretion, photophobia, and she had took multiple treatments, anti-allergic, artificial tear, antibiotics. She has very red eyes, and in one eye she had an ulcer. When we look at the upper eyelid, we see scarred, and the inferior conjunctival fornix is filing. The third case is like the precedent. It's a woman, 53 years old, treated for polyarthritis rheumatoid since 2014, followed by with secondary Gougereau, and she take a lot of treatment and consult because she has painful, and we looked at she has trichiasis, and like the other, she has a feeling of the fornix and the symblepharon. The fourth, it's also conjunctivitis fibrosis, patient with no medical history. 5 years ago, she presented a corneal ulcer, with hearing after 2 months with corneal opacification. She benefits of keratoplasty, but I received her with the opacification of the graft after 3 months. Fibrosis conjunctivitis is rare, but I think it's not really rare, but it's misdiagnosed because there is no significant symptom. It's like any dry eye, but photophobia is more severe, and we find filamentous secretion, and there has keratitis, feeling of fornix, and scars in the eyelid, and the feeling of the fornix. Conjunctival biopsy can give us the diagnosis, and it must be recognized. It's easy to recognize it. We must look at the lower fornix. We must flipping the eyelid. The treatment is we associate general treatment with internist and local treatment with steroid, cyclosporine, etc. But never operated her, never operating on them in the inflammatory phase, because the risk of serious complication, like we see the opacification of the graft, and we can have also necrosis of the sclera if we do pterygium surgery. Conjunctivitis, fibrosis conjunctivitis can also complicate the anti-glaucoma treatment. These cases, I receive it because I am neuro-ophthalmologist. So my friend, the neurologist, sent me this patient saying she has hemiparesis, some neurologic things with red eyes, and she took a lot of treatment for allergic conjunctivitis. Can you do better? So when we look at his eyes, she has filamentous keratoconjunctivitis. So it is Goujon-Sjogren. The doctor makes the assessment, and she concludes that it's primary Goujon-Sjogren related by neurologic manifestation. So dry eye syndrome, we see this in the morning. She has not specific things, but photophobia is major, and we have decrease of visual acuity because we have keratitis, and there is no correlation between complaint and objective things. We can have objective things severe with not very big complaints. It's associated with dry mouth and parotidomegaly. These cases is a patient who has treated several times for ocular herpes. She consulted because she has redness, pain in the eye, especially in the left eye, calmed by steroid eye drops. She's self-medicated with Maxidrol, and she's referred for an affected herpes that is resistant to the treatment. So this is the lesion. It's keratitis near the limbus with the dilatation of conjunctival and episcleral vessels. And when we sew to the eyelid, we find dysfunction of meibomian glands. As we look at the patient face, she have redness. It's rosacea. So rosacea is the diagnostic. It may be difficult. The patient is treated for herpes if he's adult, and vernal keratoconjunctivitis if he is children. We must look at the patient face because we have a habit to put the face of the patient in the slight lamp. It's associated with meibomian gland dysfunction, and the treatment associated, it's the same, that's meibomian gland dysfunction. This is the last case. It's a patient 22 years old, followed for rheumatoid arthritis for 2 years on methotrexate and low dose of steroid, and she consulted for painful red eye and photophobia. And we find herpes with very altered ocular surface. It's not the cases that it was a problem of diagnosis or of treatment, but it's avoid us to ask some questions. First, I think for this patient, we must use only oral antiviral therapy to avoid to alter more the ocular surface. The evolution is slower than the other herpes, I think, because she has altered ocular surface. So can oral steroid be kept? Should I decrease the methotrexate? And I think we must maintain antiviral treatment as a preventive measure, but how many times and at what dose? So before to conclude, ocular surface disease and systemic disease, there is a lot of pathology. Women more than men. Diagnosis can be difficult. We receive patients after some other doctors, so the patient receives many treatments and it's difficult to distinguish what is due to ocular surface disease, what is related to the systemic disease, and what is secondary to drop toxicity. So as possible, we always choose preservative-free drop for this patient. In conclusion, the list of pathologies that can alter the ocular surface is very long, and we can say all the cases. There is many systemic treatment can cause dryness, and this dryness can be sometimes very severe, like psychotropic, antihistamine, anti-acne, chemotherapy. We must think that all patients have dry eye, and the exam show us if we can eliminate dry eye or not. We must treat dryness and its cause if possible, and this is the unique solution to improving patients' quality of life. Thank you.